The endocrine pancreas consists of about 1 million clusters of cells, the islets of Langerhans, which contain 4 major and 2 minor cell types. The 4 main types are beta, alpha, delta, and PP, pancreatic polypeptide cells. They can be differentiated by the ultrastructural characteristics of their granules and by their hormone content, figure 24. 27. The beta cells produce insulin. There are also 2 rare cell types, D1 cells and enterochromaffin cells. D1 cells elaborate vasoactive intestinal polypeptide, VIP, a hormone that induces glycogenolysis and hyperglycemia. It also stimulates gastrointestinal fluid secretion and causes secretory diarrhea. Enterochromaffin cells synthesize serotonin and are the source of pancreatic tumors that cause the carcinoid syndrome, chapter 19. The chronic hyperglycemia and attendant metabolic deregulation may be associated with secondary damage in multiple organ systems, especially the kidneys, eyes, nerves, and blood vessels. In the United States, diabetes is the leading cause of end-stage renal disease, adult-onset blindness, and non-traumatic lower extremity amputations. Diabetes and related disorders of glucose metabolism are common. According to the American Diabetes Association, diabetes affects more than 30 million children and adults, or more than 9% of the population in the United States, of which about 1.2 million have the form of diabetes called type 1, and the remainder have type 2. Astonishingly, nearly 1/4 of these individuals are currently unaware that they have hyperglycemia. Approximately 1.5 million new cases of adult diabetes are diagnosed each year in the United States. Furthermore, a staggering blood glucose is normally maintained in a very narrow range of 70 to 120 milligrams DL. According to the ADA and WHO, diagnostic criteria for diabetes include the following. 1. A fasting plasma glucose greater than or equal to 126 milligrams DL2. A random plasma glucose greater than or equal to 200 milligrams DL in a patient with classic hyperglycemic signs, as discussed later. The endocrine pancreas 1099. 3. A 2-hour plasma glucose greater than or equal to 200 milligrams DL during an oral glucose tolerance test, OGTT, with a loading dose of 75 grams 4. A glycated hemoglobin HbA1c level greater than or equal to 6.5%. Glycated hemoglobin is further discussed later in the chapter. All tests, except the random blood glucose test in a patient with classic hyperglycemic signs, need to be repeated and confirmed on a separate day. If there is discordance between 2 assays, e.g., fasting glucose and HbA1c level, the result with the greatest degree of abnormality is considered the readout. Of note, many acute stresses such as severe infections, burns, or trauma can lead to transient hyperglycemia due to secretion of hormones such as catecholamines and cortisol that oppose the action of insulin. The diagnosis of diabetes requires persistence of hyperglycemia following resolution of the acute illness. Prediabetes, a state of dysglycemia that often precedes development of frank T2D, is defined by one or more of the following. 1. A fasting plasma glucose. Glucose homeostasis is tightly regulated by 3 interrelated processes: glucose production in the liver, glucose uptake, and utilization by peripheral tissues, chiefly skeletal muscle, and actions of insulin and counter-regulatory hormones, including glucagon, on glucose uptake and metabolism. Insulin and glucagon have opposing effects on glucose homeostasis. During fasting states, low insulin and high glucagon levels facilitate hepatic gluconeogenesis and glycogenolysis, glycogen breakdown, while decreasing glycogen synthesis, thereby preventing hypoglycemia. Thus, fasting plasma glucose levels are determined primarily by hepatic glucose output. Following a meal, insulin levels rise and glucagon levels fall in response to the large glucose load. Insulin promotes glucose uptake and utilization in tissues discussed later. The skeletal muscle is the major sulfonylurea receptor, KPLU's channel, protein, and it is critical for preventing hyperglycemia and maintaining glucose homeostasis. Although less dependent on insulin, brain and adipose tissues also extract a significant amount of glucose from the circulation. Regulation of insulin-released insulin is produced in the beta cells of the pancreatic islet, see figure 24. 27, as a precursor protein, and is proteolytically cleaved in the Golgi complex to generate the mature hormone and A peptide byproduct, C peptide. Both insulin and C peptide are then stored in secretory granules and secreted in equimolar quantities after physiologic stimulation. Thus, C peptide levels serve as a surrogate for beta cell function, decreasing with loss of beta cell mass in T1D and increasing with insulin resistance-associated hyperinsulinemia. The most important stimulus for insulin synthesis and release is glucose. An increase in blood glucose levels results in glucose uptake into pancreatic beta cells facilitated by an insulin-independent glucose transporter. GLUT2, figure 24-28. Metabolism of glucose generates ATP, which leads to the influx of Ca2+ through plasma membrane calcium channels. The resultant increase in intracellular Ca2+ stimulates secretion of insulin, presumably from hormone stored in beta cell granules. This is the phase of immediate insulin release, sometimes called the first phase of beta cell insulin secretion. If the secretory stimulus persists, a delayed and protracted response follows that involves active synthesis of insulin, the second phase. Oral intake of food leads to secretion of multiple hormones that play a role in glucose homeostasis and satiety. Of these, the most important class of hormones responsible for promoting insulin secretion from pancreatic beta cells following feeding is the incretins, which act by binding G protein-coupled receptors that are expressed on pancreatic beta cells. The two most important incretins are glucose-dependent insulinotropic polypeptide GIP and insulin influx of CA2+, glucagon-like peptide 1, GLP-1, both secreted by cells in the intestines following oral food intake. The elevation in GIP and GLP-1 levels is known as the incretin effect. In addition to increasing insulin secretion from beta cells, these hormones reduce glucagon secretion from pancreatic alpha cells and delay gastric emptying, which promotes satiety. Once released, circulating GIP and GLP-1 are degraded into circulation by a class of enzymes known as dipeptidopeptidases, DPPs, especially DPP-4. The incretin effect is significantly blunted in patients with T2D, and efforts to restore incretin function can improve glycemic control and promote weight loss through restoration of satiety. These insights have led to the recent development of two classes of drugs for treating T2D, GLP-1 receptor agonists, which are synthetic GLP-1 mimetics that bind to and activate the GLP-1 receptor on islet and extrapancreatic cells, and DPP-4 inhibitors, which enhance levels of endogenous incretins by delaying their degradation. GLP also increases energy expenditure, so the weight loss-inducing effects are likely multifactorial. Indeed, GLP-1 receptor agonists are also now approved for treatment of obesity, insulin action, and insulin signaling pathways. Insulin is the most potent anabolic hormone known, with multiple synthetic and growth-promoting effects, figure 24-29. The principal metabolic function of insulin is to increase the rate of glucose transport into certain cells in the body, thus providing a major source of energy and metabolic intermediates derived from glucose that are used in the biosynthesis of cellular building blocks such as lipids, nucleotides, and amino acids. The most important targets of insulin action are striated muscle cells, including cardiomyocytes, and to a lesser extent adipocytes, which together normally represent about 2/3 of the body's weight. The type of adipose tissue that utilizes the most glucose is adipose tissue, glucose uptake lipogenesis beige adipose tissue, which develops with exercise, and not the white adipose tissue that accumulates in obese individuals. This is one reason why exercise is beneficial and obesity detrimental to glucose control. In muscle cells, glucose is either stored as glycogen or oxidized to generate ATP. In adipose tissue, glucose is primarily used as a substrate for synthesis of lipids, which are stored as triglycerides. Besides promoting lipid synthesis, insulin also inhibits triglyceride hydrolysis and lipid release by adipocytes. Similarly, insulin promotes amino acid uptake and protein synthesis while inhibiting protein degradation. Thus, the anabolic effects of insulin are attributable to increased synthesis and reduced degradation of glycogen, lipids, and proteins. In addition, insulin has several mitogenic activities, including initiation of DNA synthesis in certain cells and stimulation of their growth and differentiation. The metabolic effects of insulin are exerted through its binding to the insulin receptor, which in turn sets into motion a series of signaling events through an array of mediators, the more pertinent of which are summarized in Fig 24.30. The insulin receptor is a tetrameric protein composed of 2 alpha subunits and 2 beta subunits. The beta subunit cytosolic domain possesses tyrosine kinase activity. Insulin binding to the alpha subunit extracellular domain activates the beta subunit tyrosine kinase, which autophosphorylates itself and also phosphorylates several intracellular docking or bridging proteins, including so-called insulin receptor substrate IRS proteins. These molecules in turn activate downstream factors such as PI-3 kinase and AKT, a serine threonine kinase that serves as a central signaling hub that mediates many insulin-dependent activities, including increased glucose uptake, reduced glucose synthesis, and increased glycogen and protein synthesis. Pathogenesis of type 1 diabetes. Tone D is an autoimmune disease in which islet destruction is caused primarily by immune effector cells reacting against endogenous beta cells